All right. Well, hello everyone who's joining us. We'll get started on time. Welcome to the webinar today. It is titled Improving Your Practice and Advocacy of Cultural Competence Through the Skills-Based Ask-In Model. And this webinar is presented by the Western Region Public Health Training Center, the California State Office of Rural Health, and the Southwest Telehealth Resource Center. Thank you. So we'd like to welcome everyone from the Western Region Public Health Training Center region, for the Southwest Telehealth Resource region, and our fellow HRSA grantees, and any other participants joining us today. This webinar is approved for CE credits. It's approved for one contact hours for CNEs, one CECH for CHES, and one CPU for RDs. Here are the learning objectives that will be covered in our webinar today that will also be later reviewed by our presenters. The planners and presenters have no disclosures. And here's some information about CNE specifically. You must be present for the entire duration of the activity, and later will be provided a link where you can fill out an evaluation as well as receive your certificate. Some tips and notes, please mute your phone and or computer microphone during the webinar. We will have time at the end of the presentation to do a Q&A. In the meantime, if you have any questions that you would like to submit, please use the Q&A function to submit those questions. And we will have a evaluation survey at the end that will provide a link, so please fill those out for us. And the webinar is being recorded and will be archived on our website. So for our presenters today, we have Dr. John Bormanis, and he is a research assistant professor in the Department of Family and Community Medicine at the University of Arizona and works as a cultural competence training specialist in the Office of Diversity and Inclusion at the U of A Health Sciences. He has been working on the improving healthcare access for underserved and minority populations for over 20 years, and has led cultural competence training sessions for nurses, physicians, residents, medical students, psychology graduates, and other healthcare professionals. Our other presenter today will be Dr. Randa Kutob. She is a tenured associate professor of family and community medicine and the director of the University of Arizona College of Medicine's Office of Continuing Medical Education. She's board certified in family medicine and has been in clinical practice for more than 20 years. She has co-authored several online continuing medical education courses on topics such as cultural competent medical care, breast cancer diagnoses, intimate partner violence, and the management of chronic pain. So I will hand it over to them now.
Thank you, Lubna, for that introduction. I'm Randa Kutob.
I'm John Bormanis.
And we're very excited to be here today to present to you this seminar entitled Improving Your Practice and Advocacy of Cultural Competence Through Using the Skills-Based Ask-In Model. So several people helped us put on this webinar today, including Lubna with the Western Region Public Health Training Center, Chris Martin, Chris Earps, and Mike Holcomb from the Arizona Telemedicine Program. And we'd also like to thank Brenda Mitchell from the California Statewide AHEC Program and the California Public Health Training Center Program. So ASK-IN is how we'll be referring to the ASCN model. That stands for Ask, Share, Compare, and Negotiate. So we found that for the past 10 years that Dr. Bormanis and I have been working on this, that this is the best way to really engage people in cultural competence and culturally appropriate interactions. It works not only for our patients, but can work with an interprofessional audience as well. If you only take one thing away from this webinar, it's the idea that if you can take a little time, a short amount of time, to ask people about their cultural backgrounds, their beliefs in regards to their healthcare, you can really enhance your patient relationships. In summary, just taking a short amount of time to ask can help you avoid cultural misunderstandings down the road and really increase the efficacy of your care with patients bridging those cultural gaps that we sometimes find. And after this seminar, you'll see that we find those frequently with a variety of patients. So we'll be talking more about that. And our focus today will be to help you build your skills. Our underlying assumption is that you're not entirely new to this field, that you already have a skill set. But we're going to show you a skills-based approach. And we prefer this approach because what we mean by a skills-based approach is a set of behaviors, strategies of interactions, and approaches that you can use, and you can apply it to any cross-cultural situation. Some forms of cultural competence training are a little different. They're more aimed at population statistics or health behaviors that might characterize large groups of people. The skills-based approach is different, though. We think that those kinds of trainings are necessary and help provide a background, but we really like the model that we're presenting today because, one, we feel that it's only when we ask patients about their cultural beliefs that one truly can see how that individual fits in to the larger population picture. Secondly, stereotyping is so common in the healthcare environment. This model presents a way to avoid stereotypes because by asking that patient as the primary informant, you then have a way to relate that patient's experience under the main heading of whatever group or population they also align with.
All right, so now that we've given you a bit of background, let's briefly review the learning objectives. Dr. Kutob already described the Askin model, ask, share, compare, and negotiate. We're also going to be talking about the culturally linguistically appropriate services standards, or class standards, of the Office of Minority Health. Next up, we're going to be talking a bit about health disparities and how they disproportionately affect minority, racial, and ethnic populations in the United States. And finally, we are going to do a health encounter vignette, which shows how this all fits together to promote culturally competent care for patients from all backgrounds. All right, so for the key elements of cultural competency, Dr. Kutob's and my research and training over the past 20 years or so has led us to believe that there are three main components we'd like you to take away with you. One is cultural self-awareness. Next one is awareness of other cultures. And the next would be tools for establishing therapeutic alliances and bridges across cultures. One of the things that we want to do is to emphasize strongly that cultural competency is an ongoing process and not just a checkbox. It's not just something, you take a training, once every year, every few years, and you say, okay, we did that, we did that. We believe that in an ongoing engagement with cultural competency is the best way to not only help your patients, but again, as we mentioned, to mitigate healthcare disparities. So one of the things that happens when we teach this seminar in a longer format is we have people do this brief cultural and health beliefs self-assessment. I mentioned that earlier for the self-awareness part. And what I'd like to do is, while you're all there, if you could look at the screen and as I read them along, think about your responses to these questions. If you like, you could even jot down some brief responses and send them in for a potential discussion during the Q&A part of the webinar. Number one, describe yourself culturally and ethnically. Number two, discuss how you think your grandparents or great-grandparents would behave when seeking health behaviors or health treatment for a health issue. What kind of approaches or providers would they prefer? What would be their cultural and linguistic preferences? 3, what is your first memory of receiving healthcare? What was the context? How did it feel? How does that influence how you see yourself as a healthcare provider today? And 4, have you ever experienced miscommunication with a healthcare professional? What happened? So now, what were your responses? What impressions of healthcare encounters came to mind as you thought about your family members or people from your background seeking healthcare? For some of you, the answer to these questions may be obvious. Others, however, may not have considered these questions before. For example, we frequently have participants who will say something like, I don't have a culture or ethnicity, I'm just white. Or, I've never experienced any miscommunication with a healthcare professional. So we find this cultural self-assessment to be a good starting point for discussion, because one of the key goals of cultural competency training is to help people who themselves are not experiencing disparate or unequal care, or from different racial, cultural, ethnic backgrounds, to start to get a sense of what it is like when culture and health beliefs play a role in healthcare decision making. Once we've broken the ice with this kind of introspective exercise, participants generally become more open to both sharing their health beliefs and seeing the value of seeking out the health beliefs of others, be they patients or providers. This also contributes to a concept called cultural humility. Terbolone and Garcia invented this term, and they described cultural humility as a need to avoid cultural stereotyping, the recognition that we cannot know the vast diversity of patient beliefs and behaviors. There's always going to be something that we can still learn about complex cultural interactions, and all the knowledge that we have is incomplete without the patient right in front of us. Cultural humility is a willingness to say, I don't know. And this willingness allows providers to act with greater non-judgmental awareness about their patients' health beliefs. No single survey, statistic, or representation can adequately represent a patient's identity nor predict how they will respond to different health challenges at different times of their lives in different contexts. For example, these days, I use a number of complementary traditional alternative health modalities to manage my health. Whereas when I was younger, I had an aversion to what I saw as scientifically unfounded practices. Today, I have a more empirical approach. If it works, I'll do it. That being said, my demographics haven't changed over the last 30 years, so the only way that a provider could account for these changes, or to even know that I have such beliefs, would be to ask me about them.
This self-assessment that you just did, the exercise, and the Askin model in general, also fit well within the concept of patient-centered care. So on this slide, you can see a definition provided by the Institute of Medicine, that's very succinct, that describes what patient care is, patient-centered care, I should say. And it's patient-centered healthcare, so it goes beyond just one medical setting or one healthcare setting. This definition really stresses the fact that it's the patient who's the center of the healthcare and not the other way around. And it focuses on an individual patient's wants, needs, and preferences. And that's really the key part. And that's the part that meshes really well with what we're trying to say here is the role of culturally competent care.
Okay, let's talk now a bit about minority health disparities. In 2003, the Institute of Medicine came out with a major report assessing research and health disparities entitled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. This milestone in the promotion of minority health disparities research continues to resonate today. The key takeaways from this slide are that minority health disparities exist throughout the US healthcare system, even after accounting for patient preferences, access to care, and disease severity. Some folks would say, well, isn't this all economic disadvantage or lack of services? And the answer is no. There are disparities in the care that patients from minority backgrounds receive and in the care that they are able to engage in. And we believe that these are tied to cultural, social, and institutional factors that sometimes are not quite visible in healthcare encounters. Cultural competence and health disparities research thus focuses on what providers and healthcare institutions can do to mitigate the cultural impediments to achieving equitable healthcare for all population groups.
The Triple Aim Initiative is a way and seeks to improve the patient care experience, overall population health, and also reduce medical and healthcare costs in general. They do this through focusing on the needs of patients. Why is this important? Well, major healthcare groups and funders support the AAA's initiative. Some of the main players in this and the people that proponents are groups like Kaiser Permanente, the Josiah Macy Foundation, Robert Wood Johnson Foundation, and also organizations similar to the Institute for Minority Health in the US, and organizations similar to that in other countries. Population health is explicitly concerned with the social determinants of health, but healthcare, keep in mind, is distributed at the individual level. And we want to explore how individuals fit into the population group. And this is something that the Askin model positions us to do.
Yes, so for example, Dr. Kutob here, to say, is both Arabic and European, a woman and a physician, an American and a Tucsonan, other identities as well. How do we tell which of these backgrounds will influence her health beliefs and behaviors? For example, is it more important that she is a woman or a part Arabic woman with a Muslim background, a physician, a nature lover? All of these aspects of identity fall under the larger rubric of culture, and her unique mix of beliefs and behaviors can only be discovered from her by asking her what she thinks.
So you should have 4 handouts. The first is a summary of the class standards. The second is a description of the enhanced class standards. And also you should have a handout on the Askin model. And lastly, a handout on an asthma card, a kind of summary of asthma care produced by the National Heart, Lung, and Blood Institute. We'll be using that asthma card and those recommendations a little later when we do a role play for you using the Askin model.
So the key point we would like you to take away from the national class standards in this webinar is the number 1 part, to promote equity at every point of access. You'll see on the class standards handout that you'll be given that many of the standards deal with issues in workplace governance, language assistance, accountability, promoting diversity and inclusion, as well as implementing the culturally and linguistically appropriate care that's necessary for all patients. This is not just good care, but as you can see from the list of organizations that require CLAS training and practice, these are professional and ethical standards to which most healthcare professionals are now being required to adhere. This slide is key to understanding the skills-based approach. Patient healthcare expectations are shaped not only by their racial and ethnic backgrounds, but also through items that can be loosely described as culture. In general, demographic questionnaires in healthcare settings stick to the most basic information about race, gender, age, and ethnicity. The healthcare providers need to engage in a more thorough assessment to discover, for example, how does care for individuals from different racial ethnic backgrounds differ in metropolitan versus rural populations? What needs or preferences might LGBTQ individuals with differing cultural backgrounds have? These are just some of the issues we'll be exploring a bit more in depth in a few moments, but we would like you to remember the key standard at the top here, which is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs.
In addition to race and ethnicity, language and culture, the Office of Minority Health recognizes that providing equitable care means recognizing that there's other important elements such as geographical, religious, spiritual, biological, and other social characteristics, and that these are also important for assessing patients' health needs and beliefs. Although we are indeed working within the field of minority health improvement, we've found that applying these standards to all patients, regardless of background, can yield very positive results. And that's one of our major take-home messages in this talk. This webinar is designed to show you how every healthcare encounter can be considered a cross-cultural encounter, not just because there are inherent differences between lay and professional audiences, but also because patients are frequently confused, and I'm sure you find this in your healthcare environments as well. they're confused about medications, they're confused about the treatment plan. And so we have a role in making this a better experience for them. And if providers assess their needs, their health beliefs, their views on treatment, we can make this more likely to happen. So we'll see this come up in the cross-cultural healthcare encounter we've sketched out for you. But first, we'd like to share with you a few more slides on race, ethnicity, and culture.
A number of years ago, when I was teaching a longer version of this seminar to a residency group in a rural California practice, one of the participants, who was an international medical graduate, asked, "Why are Americans so obsessed about race and ethnicity?" It's a very good question. And to that question, I asked the participant, "Have you ever heard about the Civil Rights Movement or the Civil Rights Act of 1964? Their answer was no. What does that have to do with this topic? Ever since that encounter, I've included in this presentation some slides about how the practice of culturally competent care started with the Civil Rights Movement and its attempts to eliminate racial and ethnic disparities in the delivery of care, at least in the healthcare environment that we're talking about today. Even though legal discrimination has been prohibited, we still find that there are many ways in which racial, ethnic, and other minorities are still not receiving equitable care, and thus the work of civil rights continues. As you can see from this slide, the Civil Rights Act of 1964 provided the impetus for later legal and then professional requirements for the practice of culturally and linguistically appropriate services in the healthcare environment. We don't have time to go over them all, but I would like you to take a quick moment to look all of these over and see the progression from the original Civil Rights Act of 1964 through the Americans with Disabilities Act of 1990, and then through the broadened professional standards of healthcare institutions and accrediting organizations in the 2000s. There are also, as it turns out, some states that require cultural competency training or working with health interpreters training for people to receive certification in their state. Another thing I wanted to point out here is that federal law requires that any group receiving federal funding for patient care per the Civil Rights Act are mandated to provide interpretation and translation services per wording banning discrimination on the basis of national origin. My apologies there, my arm went down onto the keyboard and I advanced the slide prematurely. I was viewing this slide a little while back with some students, and I asked any of them how the implementation of the Americans with Disabilities Act played out. I think this is important to give us some perspective, both historically and generationally, on how these standards are implemented and what are the means by which they come to be enacted. For example, I was a university administrator in 1990 when the Americans with Disabilities Act was passed, and I remember a number of people being up in arms saying, "What? We can't afford this. We can't afford to put wheelchair ramps around or to put up signage that helps people who have difficulties with vision and other types of accessibility issues." Today now, 27 years later, we've made great advances in infrastructure and promoting accessibility. It's by no means perfect, but it's a lot different than it was 27 years ago. And I just wanted to point out that changing access and attitudes is not always easy, but the ongoing commitment really is what makes the strides in promoting equality take place.
This next slide shows ER visits for women with asthma, defined by race and ethnicity. And as you can see, it's an example of health disparities research findings. Here you can see that women who report as non-Hispanic whites have the lowest percentage of asthma attacks necessitating ED or emergency department care. Non-Hispanic blacks have the highest rate. So given this information, how do you approach patients from different racial ethnic backgrounds? And how do you approach them in a way that helps them with their asthma? We don't think there's an easy single answer to that question. Instead, we believe that there are multiple answers to that question, and that the way to find out the answers is for asking the patients directly themselves. When Dr. Bormanis and I lead cultural competence trainings, we are inevitably asked, what's the difference between race and ethnicity? What is culture? And will patients be offended if I bring up these topics? So we thought it would be helpful to clarify some of this terminology here. As I mentioned, some folks don't know the history of how these terminology was developed of the legislation that John shared with you. And to complicate things further, sometimes people use race and ethnicity interchangeably, or they'll use them differently in one context and then differently in another. So in healthcare, we're mostly working with the US federal standards concerning race and ethnicity. And that's because the federal government instituted those demographic assessments as a means of measuring compliance with and measuring gaps in provision of that Civil Rights Act of 1964, which Dr. Bormanis mentioned a little while ago. So those of you familiar with data collection forms from the federal government for research or other purposes know that much of our health disparities research is based on what the information obtained on these forms. It also guides the way in which major organizations like the CDC and the NIH collect that demographic data. That's why on the intake forms, when you look at the racial categories, you usually only see a handful: African American or Black, Asian American or Pacific Islander, Native American or white.
So at the top of the slide here, we can see what the US Census Bureau has to say about their consideration of race. They consider the racial categories on census forms and other forms that we're required to fill out by the US federal government, which in turn provides funding to groups like the NIH and CDC to fill out these key forms. But the US Census Bureau points out that they are not trying to define race biologically, anthropologically, or genetically. In addition, they recognize that the race item for many people on questionnaires will include national or sociocultural groups. Race and racism are indeed ongoing facts of our social existence, but broad demographic categories like race and ethnicity can be incomplete descriptions of the beliefs and values that patients bring to healthcare encounters. Overly general population categories can lead to stereotyping and missing important in-group differences. Socially and culturally, we still have a long way to go to eliminate racial disparities and understand the best practices for promoting equity. Here's one thing though, people will still say, but please tell me, what is race and what is ethnicity? So I found, for those of you who want more distinct, concise definition of those, here's one here from Cornell and Hartman. They will describe race as a human group defined by its others or itself or others as distinct by virtue of perceived common physical characteristics that are held to be inherent. In contrast, on this next slide, we get a description of ethnicity as a collectivity within a larger society having real or putative common ancestry, memories of a shared historical past, and a cultural focus on one or more elements defined as the epitome of their peoplehood. Some of you or your patients may see no difference between race or ethnicity. Common ancestry and a focus on elements that define peoplehood can include race or not. Ethnicity is a shared identity passed from generation to generation, including how they perceive their differences vis-a-vis other ancestral origin groups. And again, just to situate this historically, in the late 19th century, the US, people would refer to folks from from different national backgrounds as coming from different racial backgrounds. So they would say, oh, there's the English race, the Irish race, the Indian race, etc. Early in the 20th century, US government officials began to use the term ethnicity explicitly to differentiate between different groups of Europeans. Groups from Northern Europe were seen as racially white, and those from Eastern or Southern Europe were not seen as quite white, leading to the term ethnicity being applied to groups of Europeans with perceived lower class and social status. Indeed, laws were passed in the early 20th century which set off to mark out people with Italian, Catholic, and Jewish heritages as ethnically other in a way which was interpreted by white power elites as being non-American.
So given more time, we could look into discrimination against not only the racial groups, in quotes there, like African American, Native American, Latin American, but also specifically targeted ethnic groups like Italian, Jewish, Irish, Chinese, and Japanese Americans. For now, though, we wish to point out that from just this cursory overview of the history of ethnicity, race, and immigration, we can see an ongoing struggle in the history of the American pluralist society over who is and who is not considered officially, quote, officially American, also in quotes. And we measure ethnicity in healthcare statistics. As we measure it, we are engaging in an ongoing struggle to promote equity in what has always been a society of mixed racial, ethnic, and cultural heritages.
All right, so now let's talk about the term culture. To summarize, the official terms used by the federal government and by extension healthcare agencies and professions, when they speak of race, they're speaking of social and cultural meanings applied to human physical attributes. Ethnicity refers to beliefs and traditions that are passed from one generation to another. In general, we can think of this as ancestry. You can see how the two sometimes overlap and sometimes they're different. And this is constantly changing through the years. So for example, a recent Pew Hispanics Trust survey found that almost 2/3 of American Hispanics said that their race was Hispanic. Other surveys have wide-ranging responses from Latinos and Hispanics on mixed racial heritages such as white, Amerindian, and other. So what will make a difference in your healthcare encounters is to, again, find out how do individual patients see themselves or how do they wish to be seen with these demographic information and in addition to other aspects of the backgrounds that are not listed on the demographic forms. And this is why we then come to the term culture. There are complex cultural differences in health beliefs, as well as factors such as discrimination, racism, and implicit bias, and how these can affect how patients from all different backgrounds, but specifically from minority backgrounds, are treated in the healthcare setting. And this is one of the key things that we use. We're using these demographic studies and data to help us to determine the work that we are doing in healthcare disparities. As I mentioned, culture can encompass race and ethnicity. It also brings in other aspects of identity, as the Office of Minority Health recognized in 2013, such as spiritual, religious, regional, and other forms of cultural affiliation. The point that we wish to make is that no patient's health beliefs and behaviors can be deduced from just one demographic category, or even a couple of them. Overlapping identities and the challenge of providing equitable healthcare in a pluralistic society includes an awareness of the diverse and ever-changing factors that make human culture and identities. Culture is ultimately an opportunity. It's a chance for both providers and patients to expand modes of more effectively knowing, understanding, and communicating with each other. On this slide, I just wanted to show you a little bit of the work that the federal government is doing to expand their collection of demographic data. So we are familiar with the Hispanic category that you'll frequently see on demographic forms, and with that, they're proposing that we'll say, oh, within Hispanic, we'll want to have listed regions of origin for folks. So we'll have, Mexico, Puerto Rico, Cuba, El Salvador, etc. This also happens for African Americans, for whites, or European Americans. Under the white category, you can have people from areas as diverse as throughout the entire Middle East. They are considered white in US demographic standards, but you might find, oh, there are different cultural differences, even though they checked off white on the demographic box. Let's see. One example of how this kind of expanded demographic research can help us comes into health disparities research, where in-group differences are significant. As one example, there are studies showing that women from Puerto Rican backgrounds have higher rates of breast cancer than women from Mexican backgrounds. Why is this? How does this occur? This is just one of the wide varieties of in-group difference that an emphasis on culture seeks to better understand. Many people, both those raised in the US and new to live in the US, are unaware of the legal, historical, and ethical foundations for the research into cultural competence and health disparities. This is why, as I mentioned earlier, I had the aha moment a number of years ago, first working with people who were newer to the US, and then realizing as I discussed these things through the years, that even people who had been raised in the United States weren't quite aware of, why are we using these terms differently? Where did the federal government get the idea to use these terms, etc.? One of the things that we found through discussing these issues and their historical background is that some people are afraid to ask about race, ethnicity, and culture. But in general, we've found in our research and the work of our colleagues that most patients welcome an opportunity to talk more about their culture if given a chance. For example, when teaching this seminar a while back, a Navajo participant stated that she had spent a number of years doing health interpretation for her father, and never in that time did anyone ever ask him what he thought was going on with the disease or how he felt about the treatment modalities. The student represented that a lot of suffering that they went through and a lot of uncertainty could have been avoided if they just had a better sense or felt that their point of view was heard.
So this is a great lead into the Askin model. So I also wanted to give you a little background about the model before we go on to the clinical vignette. The model recognizes that you won't always be able to know everything about one specific cultural group. But if you have a large number from a particularly identified cultural or racial or ethnic group in your practice, then it does behoove you to get to know a little bit more about that population. In my practice right now, we see a lot of refugees and immigrants from Somalia, as well as now Syria. So as a provider in that practice, I do feel it's my responsibility to learn a little bit about their background, what their experience of healthcare was like in their countries of origin, why they immigrated to the United States. But where the model comes in is a recognition of the second bullet point, sorry, on the last slide, that all patients and providers have cultures that shape their identity. And I realize I said and providers too, because as providers, we have a culture. That could be things like LGBTQ status, class, which we rarely talk about in cross-cultural training, but is always there. Spirituality, rural, all these things are intersecting our views of the interaction. And the take-home message here is always be sure to ask about an individual patient's relationship to their health beliefs and their cultural values. The next slide shows our model of a healthcare encounter. And this is based on the pioneering work of Arthur Kleinman in the 1970s and 80s. And as you can see on the left side of what I believe you see on your screen is the provider's model of the patient's disease. And on the right is the patient's model of what Kleinman referred to as their illness. And in the course of a healthcare interaction, these two worldviews have to merge in some sort of negotiation. And that negotiation ultimately leads to a health outcome that benefits the patient. That's the ideal scenario. But in reality, we know there are factors that you've seen outlined in the boxes that were our additions and my additions to this model. Things like communication style, bias, stereotyping. And although those things are definitely factors on the provider side, they're equally important on the patient side. things like health beliefs, view of self-efficacy, and barriers to care. So here is the Ask-In model. And basically the steps are ask about a patient's health beliefs, what they think is the best treatment, how that health concern may have been dealt with in their family in the past. So for example, when I'm talking to patients about diabetes, and unfortunately in my practice, I talk to people fairly regularly about newly diagnosed diabetes, asking them about those things. What do you think is causing the diabetes? What do you think is the best treatment? And how does your family handle this in the past? Do you have any experiences, bad or good, with the management of diabetes? So asking is the first piece. Probably, honestly, in some ways, the most important. Next is sharing. So as a provider, I want to share my biomedical model of disease. I mean, they're here to see us because they want to hear about the biomedical model. So it's important to share that model with using lay terminology. So when I talk about diabetes, I do talk about organs like the pancreas. I talk about insulin as a key that opens up the tunnel receptor on a cell to allow glucose to go in. So I share that in a way that I think patients can understand best. And then the next step is for both of us to compare both our views. Sometimes those views will be very close. Sometimes the views might be more widely apart, but we can seek common ground. And that's where the negotiation comes in, to find an outcome that both you feel comfortable with and that it will also benefit the patient that they accept. So next, we're going to demonstrate with a clinical vignette, and I'll share with you the background of the vignette in just a moment. But we really want to stress that the Ask-In model can be used in all sorts of different clinical circumstances, even ones where you think that cultural factors are not such a big role. We're using examples from our own cultural background for a number of reasons. As we've explored diversity and cross-cultural issues that we encounter in healthcare, we want you to think about not only your responses to that original or the self-assessment questionnaire that you did with Dr. Bormanis just a few moments ago, but also think about how stereotypes about minority and majority groups can shift depending on the context. Individuals who are perfectly comfortable in some cultural contexts can feel alienated or afraid in unfamiliar circumstances. And we'll see this in this vignette that we're going to portray for you of an immigrant patient experiencing the US healthcare system for the first time. Furthermore, counter-stereotypical examples are helpful to fight implicit bias. So we're doing our vignette dealing with a German immigrant, which maybe is not what you might have anticipated from our webinar, but that's what we're familiar with, or one of us is. In our mind, this serves two purposes: to encourage you to think about culture in every clinical encounter, and to take a deep look at how your own assumptions about cultural needs of a particular individual may not match with that larger epidemiological picture, although sometimes it can as well. And secondly, we believe that the skills-based Ask-In approach is preferable to checklists of, this population does this, and you should do this, or that population does that, and now you need to do that. And we also find it preferable to using one person as a representative of a whole population. Remember that when we say, okay, this person is representative of the population, that's really only an N of 1. And scientifically speaking, we need more than that to characterize an entire population. So with that background said, we're going to jump into the clinical vignette, and I'll give you a little bit more background about the vignette. I am going to have to read my role here because Dr. Kutob cannot memorize her lines. And every time we try to do this and I ad-lib, I end up adding too much and it goes too long. So
yeah, and we're going to let you just read there who I'm portraying, and this is my sense of my family and my relatives. So, for example, the German glasses of Ellie's. So trying not to stereotype, but this is all stuff that straight out of my background, and we hope you'll see how it relates to the points that we have been discussing. As we go along and we're discussing, I'm going to try to advance through some of the slides. Watch your slides and you'll see some of the learning points that are coming up as we go along.
Good afternoon, Mr. Bormanis. My name is Dr. Kutob.
Hello.
How can I help you today?
Well, I had an attack of asthma and went to the emergency clinic.
And what did they do for you there?
They gave me a nebulizer treatment, and then my asthma got better. When I left, they gave me a prescription for medicine, have it here, called albuterol.
And has that been helping you manage your asthma?
Manage my asthma? You must be joking. I've managed my asthma all my life. This drug just makes me fucked. How do you say in English? Crazy.
Oh dear, that's not supposed to happen. What do you mean by crazy?
I mean, my heart goes crazy. You Americans use very strong drugs.
I'm sorry to hear that you had a bad experience. Can you tell me more about what happened with the albuterol?
Well, I don't like it. I've never had a medicine this strong before. It makes my heart feel like it's going to jump out of my throat. Same with the nebulizer treatment in the emergency clinic. I got so afraid.
Oh, Mr. Bormanis, I'm so sorry that you had those experiences, but I think we can help you to make the albuterol treatments less troublesome for you. Albuterol is a medicine that opens up the passageways in your lungs, and it can temporarily, as a side effect, increase heart rate. That's a really well-known side effect. Did your heart rate go back down again after you took the medicine?
Yes, after about half an hour it was better.
And was your breathing better?
Yes, it was, but I don't think it's worth it.
Oh, okay. Well, Mr. Bormanis, I hear that you're not happy with the albuterol. You mentioned earlier that you have managed your asthma all your life. Can you tell me more about that?
Oh, yeah, it's never really been too bad before. It's only when I came here to Arizona that I ever had it.
Hmm. And so that's very useful information for me. So to reiterate, your asthma got much worse after you came here.
Yes.
And when you were back in Germany, how did you manage your asthma?
So the normal way with herbs and steaming.
Could you tell me more about the herbs and steaming?
Yeah, everyone knows this. When you feel the tightness in your chest, or you have a cold, or making a pot of boiling water, you put in some chamomile and eucalyptus. You cover your head with a towel, and then you put your head over the pot and breathe. It's always made me better before.
That is really interesting, Mr. Bormanis. Thank you for sharing it with me. So just to recap, your asthma was under control with the steam inhalation and the herbs in Germany, but it got worse when you came here.
Yes, that's it. The herbs don't seem to work here.
Well, I think that there's a couple of things going on. First, the environment here is probably much drier than you're used to. And on top of that, there are a lot of plants and pollens that you haven't had to deal with before. I believe these environmental factors may be exacerbating your asthma, thus necessitating the use of additional treatments.
That's maybe true, but I hate that albuterol.
But you're worried that your asthma is still not under control, yes? Okay, let's see what your peak flows are. Have you ever used one of these before? This is called a peak flow meter, and it's a way to measure your asthma. If I can open it up. Thank you. And what I'm going to have you do is blow into this tube, wrap your mouth around this end, close your nose, and blow out as forcefully as you can.
Okay.
Okay. All right. So that is about 420. How are you feeling with your asthma right now?
It's a little bit tight, hard breathing.
Okay. All right. Thank you. And have you used your albuterol today?
No, actually, I only used it the one time, and I was never going to use it again after that.
Can I please see your albuterol?
Yes.
Okay. So I see that you were instructed to take 2 puffs of albuterol. Is that what you did?
Yes.
And that made your heart race or go up?
Yes.
Okay. Mr. Bormanis, I believe I can help you find a better way to manage your asthma here in Arizona and avoid another ER visit. First, I'd like you to get a peak flow meter, kind of like what I showed you here. I can help you get that. And you can actually start monitoring your breathing at home.
Okay.
And then I think we might have to try just 1 puff of the albuterol in combination with something called a corticosteroid inhaler. This will help your lungs open and help prevent you from having further asthma attacks.
Steroids? You see steroids? You must be joking. Those are dangerous.
I do understand your concerns, but this medicine is not dangerous in the doses that I'm going to prescribe it. And can I further explain to you how the corticosteroids work?
Yes.
So basically, thank you. Okay. I'd like you to use an inhaled steroid called fluticasone. Most of the medicine stays in the lungs. Very little goes in the rest of your body.
Are you saying there's no side effects?
I understand. We'll get to that in a moment. The fluticasone reduces the inflammation and the swelling in your lungs, and that causes minimal side effects. But this inflammation in the lungs is really at the heart of what's causing your asthma. So if we treat the inflammation, we actually treat the asthma. I've used it with many patients for more than 2 decades, and in my experience, and also in the medical scientific literature, there is strong evidence that fluticasone can not only help dramatically reduce asthma attacks, but also can cause very few, if any, side effects.
This isn't just what the pharmaceutical companies are telling you what to say?
I assure you, Mr. Bormanis, the science regarding the safety of this medicine is sound. Furthermore, if you use the fluticasone, I think you can cut down on the amount of albuterol you need, and that will help avoid the racing heart.
So now you want me to be taking 2 drugs? What about my herbs? Maybe I could just use more eucalyptus.
I have no problem with your continued use of the eucalyptus, the chamomile, or even the steaming. The scientific literature shows that these interventions can indeed help with colds and milder forms of asthma, as you related. But for your exacerbated asthma, we need to give you some more tools to help you manage. Would you be willing to give these other medicines a try?
I suppose I could, yes.
If you don't like them, we can try something else. But from the perspective of my training and experience, this approach is very likely to help you.
Okay, so you want me to use this fluticasone and have the albuterol?
Yes, that's correct. I'd like to also give you a spacer or an inhalation chamber. It looks like this. It's a tube that helps hold in the medicine so you get more of it with each dose, and that allows you to be more efficient in your treatment of medicine and treatment of the asthma.
Oh, and that perhaps will then maybe cost less because I won't have to use as much medicine.
Exactly, exactly.
Okay, well, I'm willing to give it a try. But if I start to look like one of your so-called American football players, I'm going to throw it in the garbage.
I assure you that won't happen. Those are very different steroids. Do you have any more questions for me?
No, I think that will do for now. Thank you for taking the time to explain all of this to me. I almost didn't tell you about the herbs. I am scared of having another asthma attack, but I want to do what's best.
I really appreciate your sharing your ideas about using herbs and the steam with me. I believe you'll do better with these additional tools and medicines. I would like it if you could come back in another 4 weeks so I can see how you're doing.
Thank you very much for your time, Dr. Kutob. I'll see you in a month.
See you then. All right, so just to kind of recap, so we went through the patient, we learned more about the patient's unique experience through asking about it. We understood a little bit better about his convictions, his perceptions of the healthcare industry, and we shared our view as well of our biomedical model.
We talked about mistrust of healthcare professionals, and one of the things I'd like you to be thinking about is, how does this relate to your family or people you know from cultural backgrounds that are similar to yours, or patients that you've dealt with in your clinic, because this comes up an awful lot. Mistrust, as well as people's use of traditional medicine and healing practices, immigrant health. Again, I felt comfortable portraying this person because I have a number of German relatives who will winter here. And indeed, this is what we do. And what I represented there, that's exactly what I do for my asthma. I've done it for years. I just didn't know why.
Yeah, sure. So we compared. So there was a gap there between what he was used to in Germany and what we do here in the United States. And this is an opportunity for those of you listening to pause and reflect on how this interaction might play out with different cultural groups. In some ways, it might sound very familiar, with other groups perhaps very different. There's definitely, the interaction showed a fear of manipulation by healthcare providers. I unfortunately find a lot of my patients have that initially. So what we can do to ease that fear is very important.
Yeah, so just to summarize, because we're getting near the end of the webinar here, we wanted to have you take away these key points. Your patients are empowered to make better healthcare decisions with healthcare providers as allies. And the best way that you can be allies with your patients is to know where they're coming from and where they're situated in the whole healthcare encounter with their health beliefs, how they respond to institutions, etc.
And the Askin model can help you personalize that care through engaging with individual perspectives. And so by engaging with individuals, then you can actually learn about their cultural group at the same time avoiding stereotyping and assuming that just because a person's from a group that they are going to have this belief or that belief.
We believe that cultural competence should be a part of every encounter. One of the problems is sometimes people say, oh, cultural competence, that's just for these particular groups here, small groups, not for everyone. And sometimes that leads people to see those groups as, every now and again we'll do cultural competence, but maybe not today. No, we believe that if you practice it every day with all patients, that enhances the ability to promote it for the times when you do need it, especially for underserved populations and health disparities.
And last point on the slide, using the class standards to promote equity at every point of access for our patients, from their first encounter with the healthcare system to when they go back home.
Great. If any of you want more in-depth look of this, there's a line you can go back and look later at this and find there's an online course for CMEs. There's the references, and now we have a bit of time for Q&A if Lubna has some questions for us that people had.
Yes, so we have just a couple questions that came in, and everyone else, if you have any questions, please feel free to use the chat box or the Q&A box to submit those. So the first question I have is, what suggestions or resources do you have for finding out more about specific ethnic or cultural groups?
That is a good question. The Office of Minority Health has some resources available. Again, I usually approach it from the historical perspective. Different federal agencies, sometimes CDC will have it, sometimes the State Department, because they handle like travel advisories and things like that, and so they have good descriptions of politically what's going on in a particular country, and that's relevant to like people immigrating to the United States. I don't know, George,
yes.
John, if you have thoughts.
Yeah, federally speaking, I say go to the CDC, cdc.gov, type in whatever group you're interested in. That will lead you to a number of articles. Also, same as you do with the Office of Minority Health at omh.gov, and you will find that different groups will be linked to, and you can spread out from there.
Great, thank you. And then another question came in is, how would you address a patient who has religious beliefs that that don't necessarily believe in taking medicine?
Mm-hmm. Well, what I usually tell people when I get asked that question is that, remember, they came to you for a reason. So if they truly had no interest in what you were offering, they probably wouldn't be entering your healthcare clinic or your healthcare environment. So our goal as providers is to find out, well, what is it that they can get from us or that they're seeking to get from us? Maybe it's they don't believe in typical Western medicines, but they will be willing to take an herbal treatment. Maybe you can find some common ground there. But again, I would encourage you to explore, if it seems like they don't want to do the standard recommendations, why are they there? Because they're there for a reason. So, and that's where the Askin model can help.
Another question also that came in is, would you use the same model for engaging patients with alternative lifestyles that are seen as less acceptable in our culture? For example, those with drug addiction not seeking help.
So with those kind of models, again, if the person's coming to see you, there's a reason for it. And a nice add-on to the Askin model is motivational interviewing. And so that's a whole nother skill set that deserves hours and hours of time to train. But it's really a way of asking the patient to explain, what it is they hope to get from the encounter. And if they're coming to see you, even someone who has issues with substance abuse, the underlying theme of motivational interviewing in 2 sentences or 2 seconds is basically that they want to make a change. And that through motivational interviewing, you help them understand what the changes they want to make. So, so there's a slightly different strategy that folds well into the Askin model that you can use in those situations.
And then we had a common question come in as, I did not time the interaction, but do you believe realistically in most practices there is time to do this? What if one PCB embraces this approach, but a coworker overrides the approach?
Yeah, that's a great question. It happens all the time. So there's never enough time. That's the quick answer. But the premise of this is that if you take time in the certain circumstances, like think about those important, really important times, like the times where you go into a room, patient's doing something, and I'm sorry, this is from the provider perspective, that just does not make sense. And you're just like, you're recommending this, they're doing that. It just doesn't make sense. So that's the time to sit down and say, what do you think? What do you think's going on here? What do you think is this disease? What do you think is the best treatment? The other time is when you're newly diagnosing illness, especially like chronic disease. Asthma and diabetes are great examples. But do I do this with the sore throat person that comes in, person with sore throat? No, I don't. I don't do it with every single patient encounter but it doesn't actually take that much time. If you try it, I guarantee you'll see a little shift in the interaction with your patients. And I'm convinced, although we haven't studied it yet, that is that little shift that actually activates them and engages them more in their treatment.
Yes, I mean, many times you'll have no conflicts. Patients will be doing exactly the things you want them to do, and the treatments will work. But as we saw in the example that I was portraying, I know from my background and from people in my family that there will be folks who will just throw out the medicine, say, I had a bad side effect, they throw it out, and they don't bother to talk to the doctor. Now, this gentleman is portraying then went back to the ED and had another visit for asthma attack. Then we see that the time that would have been spent teaching him how to use a peak flow meter and how to use a spacer would have promoted health care savings. You say, well, it didn't save me money, but it might, for your own practice, that'll save it. And as we move more to value-based reimbursement systems, such things as patient satisfaction, patient outcomes will start to play a role in how our care is being evaluated. So this is going to be something that's going to be negotiated over the next few years. How do we make time for doing this? There is also, I mentioned my students, there are billing codes for this. When you have people with limited English proficiency, or when you have to have extra long visits for somebody that is having a problem with adhering to medication or getting their illness under control, it can be financially viable if you work with the whole group to make that happen.
Yeah, building on what John said, I want to put in a plug for interprofessional care. So we gave this example because I'm a healthcare provider, it's familiar to me, but I'm sure there's pharmacists listening to this webinar. Normally I would say, hey, make sure that you ask the pharmacist how to use this. I might show you in my office, but we need to use our team more effectively than we do now. And the team is very broad. So definitely interprofessional care folds well into this model as well.
Great. So it is 1:02. We do have a couple more questions. So if we can either answer them later, or if you're open to staying for a couple minutes.
We can go on. Yeah, that's fine.
Great. As we have most of our viewers still on as well.
Wonderful.
So how can the Askin model assist providers, caregivers in the cannabis industry? Specifically, veteran administration and many public-private group providers aren't allowed to recommend the herbs over the strong science in opioids.
Oh, that's a great question too. I'm sort of in the same boat because I work for a state university, so I can talk to people about that. I don't think there's a gag rule about me talking about it, but in my physician group, I can't prescribe it. And certainly there are some health policy concerns there. I don't have a simple answer for that one because it does engage changing our view and issue with. There's lots of barriers to research on marijuana and its therapeutic use.
This can hold up practitioners when I'm working with folks who have prescribing rights. They will say, you know what, I will not talk about things that I can't prescribe or that haven't been put through RCTs, randomized controlled trials. But as Dr. Kutob mentioned, because of the laws in this country, there has been a disallowance of federal funding for research into the efficacy of cannabis use. And so some providers will take refuge in that or avoid the issue by saying, well, there hasn't been an RCT and I can't say. This is very similar though to the traditional medicine thing. So people will be talking about the herbs and things that they're using or their preference for other systems like Ayurvedic medicine or people who work with curanderos. The important thing, though, I think, is that if you approach the patient encounter with non-judgmental awareness and make it safe for the patients to talk about their desires and preferences, at least you know what is going on with their treatment and what things that they're trying, and that allows you to build trust with the patient, and for the things that you either are legally able to or feel comfortable with prescribing, you can do that in conjunction with the knowledge that you're aware of the other treatments that they're using and look at the literature on that. For example, I did lit church on herbal inhalation of chamomile and eucalyptus-stemia, and there are trials on that, and there's science. So you can go and say, yeah, there's solid science on this. Other stuff, not so much, but you'll want to know, and then you can find out more about what your patient is feeling, and potentially spot points where adherence may be a problem. Right? People will have a different role.
Great. And one last question we have is, as a patient, if my physician is not behaving in a culturally competent way, what would I be able to do?
I do some lay health education lectures, and I always tell folks that, if we as providers use medicalese jargon to say, hey, I didn't understand that. Some physicians respond positively to gentle nudges that they could be spend a little bit more time with their patients, and some honestly will not. And as a patient, I say, if you feel like you can't communicate with your provider, then definitely unfortunately look for a different provider who you can communicate with. But the other thing I tell people regularly is bring a family member or someone who can also be an advocate for you, and sometimes that can achieve a lot more than one individual patient alone can. So those are just a couple strategies.
Okay, it is 1:06, and yeah, I think those were kind of the last questions. There's some coming in, but we can address that later.
Okay.
Sure, yeah. Now, do you need to tell people about the contact info?
And you may not see me, which is fine, will not shift, but so here is the continuing nursing education information. Please go to cne.nursing.arizona.edu to submit the evaluation form. And please, you have to submit this by 11:59 Pacific Daylight Savings Time today in order to get your CNEs. And the link to this is also in the chat box for everyone. And if you're looking to get CECH and or CPU completion certificate, please fill out this form within the next 7 days. Sorry, that parentheses date is incorrect, but this also link is in the chat box for you to access.
And then just
thank you. And of course, at the end, there's an evaluation survey in regards to the webinar you saw today. We'd love to hear from you about what you heard, what you liked, what you didn't like, and what sort of topics you're interested in the future.
Okay.
And that link also is in the chat box for you to access.
Right, so thank you very much for spending the last hour with us.
Thank you, everyone.
And have fun and try to practice this in your clinics. I think you'll be positively, perhaps surprised by the results you see.
Thank you.
Thank you both.